Hi there, thanks for joining. My name is Christina Thibault. I'd like to thank the conference organizers for giving me the opportunity to share our data with you. My talk today is about antibiotic resistance profiles by azithromycin or ceftriaxone susceptibility status among Neisseria gonorrhea isolates in King County, Washington. The gonorrhea bacteria has developed resistance to nearly all recommended treatment. In the US, dual therapy with azithromycin and ceftriaxone is the current recommended treatment for now. However, last year in King County, nearly 10% of patient cases who underwent susceptibility testing demonstrated resistance to azithromycin, which I am abbreviating as AZI in these slides, and just under 1% of gonorrhea cases were resistant to ceftriaxone, which I'm abbreviating as CRO. Gonorrhea control largely relies on our ability to successfully treat the infection. Alternate regimens may be needed for potential treatment failures. Our objective was to compare the antibiotic resistance profile of gonorrhea isolates resistant versus susceptible to azithromycin and resistant versus susceptible to ceftriaxone. Specimens were collected as part of CDC's Strengthening the U.S. Response to Resistant Gonorrhea, or SURGE activity. Clinicians collected gonorrhea cultures from patients with genital and/or extragenital infection. Patients were seen either at the public health sexual health clinic or at one of 5 private clinics in the Seattle area. And for this analysis, we included specimens collected between June 2017 and February 2020. Isolates first underwent E-test susceptibility testing to measure the minimum inhibitory concentration, or MIC, to azithromycin, ceftriaxone, and cefixime. The MIC is the amount of drug needed to inhibit bacterial growth. So having a higher MIC means that more of the drug is needed to stop bacterial growth. All isolates then underwent additional susceptibility testing using the agar dilution method to measure minimum inhibitory concentration to ciprofloxacin, gentamicin, penicillin, and tetracycline. We did one analysis where we compared azithromycin resistant versus azithromycin susceptible isolates. And we did another analysis where we compared ceftriaxone resistant versus ceftriaxone susceptible isolates. We looked at prevalence of resistance to ciprofloxacin, gentamicin, penicillin, and tetracycline, which are all treatments that have been used to treat gonorrhea. We evaluated statistical significance using chi-square or Fisher's exact test. On to the results. We had a total of 1,573 isolates from 1,423 patient cases. Some patient cases contributed more than one isolate if they were cultured at more than one anatomic site. 40% of isolates came from urethral infection, 34% came from the rectum, 23% came from the pharynx, and just 3% came from the endocervix. The majority of extragenital isolates came from male patients. The overall prevalence of azithromycin resistance was around 8% in both patient cases and in isolates. So remember, we have a few more isolates than cases. By anatomic site, azithromycin resistance was most commonly found in rectal isolates at around 10%, followed by pharyngeal, then urethral isolates, and only 2% of endocervical isolates had azithromycin resistance. The overall prevalence of ceftriaxone resistance was very low, 0.4% in both patient cases and in isolates tested. There is some variability by anatomic site, but the numbers are very small. No isolates were resistant to both azithromycin and ceftriaxone. Now we're focusing just on azithromycin. Azithromycin resistant isolates, shown in the dark blue, and azithromycin susceptible isolates, shown in light blue, had similar levels of resistance to ciprofloxacin, 36 versus 44%. Azithromycin-resistant isolates were less likely to be than susceptible isolates to be penicillin-resistant, 1 versus 13%, a statistically significant difference, and they were more likely to have tetracycline resistance, 68 versus 18%, also statistically significant. No isolates were resistant to gentamicin. Among ceftriaxone-resistant isolates, shown in dark green bars, all 7 were resistant to ciprofloxacin, penicillin, and tetracycline, while just 43%, 12%, and 21% of ceftriaxone-susceptible isolates, respectively, were resistant. These differences were all statistically significant. Again, no isolates were resistant to gentamicin. And I'm not showing it here, but we did look at these comparisons restricted to each anatomic site, so urethral, throat, and rectum. And the results of the statistical testing by drug were consistent across anatomic sites. So we found that 1/3 of azithromycin-resistant isolates were also resistant to ciprofloxacin, and 2/3 were also resistant to tetracycline. We observed that all ceftriaxone-resistant isolates were also resistant to ciprofloxacin, penicillin, and tetracycline. This is, in fact, consistent with the Pen-A mosaic of the penicillin binding protein. We do recognize limitations in our analysis. The majority of the isolates came from patients seen at the public health sexual health clinic, and these cases were only 15% of the gonorrhea cases diagnosed in King County during this time period. So these patients may not be representative of our county-wide gonorrhea cases. In conclusion, resistance to multiple antibiotics was common among these isolates. Differing patterns of susceptibility have the potential to inform empiric alternate treatment regimens for treatment failures in the absence of susceptibility testing. And here's my contact information, and thank you for your attention.
Good afternoon. My name is Margie Smith, and I'm the Surveillance and Evaluation Coordinator in the STD section at the Illinois Department of Public Health. Today, I've been invited to discuss our project, Gonorrhea Treatment Failure Surveillance in Illinois. Today, I would like to review this procedure with you, discuss the results from our first 2 years, and share results of a process evaluation of this procedure. In Illinois, there were a total of 25,422 cases of gonorrhea in 2018. Preliminary data for 2019 shows another large increase in gonorrhea cases to around 30,000. As you can see from this graph, our cases started to sharply climb since 2014, with an almost 60% increase from 2014 to 2018. Illinois does contain a separate CDC-funded project area of Chicago, so we like to look at cases in the city compared to the rest of the state. Recently, cases have been almost evenly divided between the city itself and the rest of the state. As most of us are aware, gonorrhea has continued to develop resistance to each class of antibiotics that have been recommended for treatment. The last class of antibiotics recommended are the cephalosporins. The current CDC recommended treatment for gonorrhea is dual treatment with the cephalosporin ceftriaxone and azithromycin. Since this is our last class of antibiotics to fight gonorrhea and our cases have been increasing, we want to proactively monitor our gonorrhea cases for any possible antibiotic resistance. In Illinois, gonorrhea cases are entered and reported into the Illinois National Electronic Disease Surveillance System, or INEDS. This is a web-based system that we are able to export data from for further analysis. For our gonorrhea treatment failure surveillance project, we created an Access database that we import all the gonorrhea cases into. A procedure then runs that looks for persons with 2 gonorrhea cases in the last 60 days where the first case was reported with adequate dual treatment. To be more broad, we consider any combination of dual treatment adequate, including the alternative treatments recommended by CDC. In 2018, we did consider azithromycin 2 grams as adequate treatment, but it has since been removed. This procedure was established and piloted with 2 jurisdictions in our state in 2017 and expanded to 94 of our 97 jurisdictions in 2018. Chicago is excluded because, as I mentioned before, they are a separately funded CDC project area. 2 other jurisdictions are excluded because one already receives extra funding from us to do more intensive follow-up on gonorrhea cases, and the other jurisdiction is a high morbidity jurisdiction that does not have the capacity right now to do this follow-up. So here's how the procedure works. The procedure is run quarterly in the Access database. Interview records for patients are printed and faxed to the local health department where the patient resides. Local health department staff attempt to contact the patient for interview. LHD staff returns the interview record via fax to the STD section. The interview record information is then entered into an Access form for analysis. The procedure did start to run monthly in 2020 until March, when most of us were pulled away to assist in the COVID pandemic response in Illinois. Here's a workflow of the procedure. At the top here, we identify our cases and send the interview records to our local health departments. Over on the left, if they are unable to locate the patient, they document that on the interview record and send it back to us. In the middle, if they are able to interview the patient and partners are identified between the 2 positive test dates, the patient may have been re-exposed, and we ask the local health department to try and follow up with the partners for testing and/or treatment. All the way at the right, if they are able to interview the patient and partners are not identified, the patient is considered a possible treatment failure, and we then start the discussion of obtaining specimens for antibiotic susceptibility testing. Here's a separate workflow for obtaining specimens for antibiotic susceptibility testing. We could probably have an entire presentation just on this, so I will try to cover the basics. We arrange for specimens to be collected from the patient for nucleic acid amplification testing and to be cultured at one of our state labs. The specimens are shipped to the state lab. The NAT specimens are run, and the swab specimens are plated on an in-tray GC for culture. Further testing is done if growth is observed, and coordination is made with the CDC lab to send specimens there for AST. At this time, our lab is not performing AST. Again, this could probably be its own discussion, so if you're interested in more details about this, please reach out to us directly by email, and we can provide more information. Here's an example of the interview record. I'm going to zoom in on sections in the next few slides, so please don't try to squint. Overall, the top half of the form is information pre-populated from the database, and the bottom portion is completed by the local health department. The top half covers the patient's demographics, the testing information, and treatment that was given. All of this information is pulled from our INID system into our Access database. The next section covers risk factors. How many days did you wait to have sex after treatment? Were your partners treated? From the first diagnosis to the second diagnosis, who did you have sex with and what types of sex? We also found it important to ask questions about travel, since most of the documented cases of ceftriaxone and azithromycin-resistant gonorrhea cases occurred outside the United States. We have the questions, did you have sex with someone while you were traveling outside the US, and where did you travel? And have you had sex with someone who traveled outside the US, and where did they travel? The final portion of the interview record asks the patient about any symptoms they had and any partner information they can provide us. Here are our results. In 2018 and 2019, 310 interview records were sent. 261 or 84% were returned back to us. Of those, around 50% identified a partner between their first and second diagnosis and were considered possible reinfections. Almost 40% were unable to be located for interview. 5% refused to be interviewed. 2% had their treatment reported incorrectly in INIDs and were not initially treated with dual treatment. One case was identified as possible gonorrhea treatment failure. For that case, the patient first tested positive at the throat, genitourinary, and rectum. They were treated with the recommended dual therapy of ceftriaxone and azithromycin. The second test, almost 2 months later, the patient remained positive at the throat and claimed no sexual partner since the first diagnosis. The patient was retreated with ceftriaxone and azithromycin and the third test came back negative. We wanted to know more about how this procedure was working with our health departments and made it our targeted evaluation plan through our CDC grant in the fall of 2019. 6 jurisdictions responded out of 8 that were contacted for interview. We had individual calls with each jurisdiction and asked them 9 questions. The questions covered gonorrhea antibiotic resistance in general, the procedure for treatment failure surveillance, the interview record form, and the logistics of how the procedure is run. We compiled the responses and implemented a few changes based on the feedback we received. The changes we made from the local health department feedback was to run the procedure monthly instead of quarterly to be able to more timely follow up with patients, remove a question on the interview record regarding HIV status as we weren't using this information anyway, and we added 2 questions to the risk factor section. Those questions were regarding how long they waited to have sex after treatment and were their partners treated. We found this evaluation very useful, and it helped us understand how the procedure was being executed by the local health department. We wanted to share this information with all of our health departments and created a 1-page fact sheet to distribute to all. Here's the fact sheet that we distributed to our health departments. We covered antibiotic resistance in general, the treatment failure surveillance procedure, results from the procedure, and results from our interviews with the local health departments. We were very excited to be able to get to that last stage of evaluation around reporting out our results. We hope this provided our local health departments with more detail about why we are asking for their assistance in obtaining this additional information on gonorrhea cases. I want to thank you for allowing me to present our information today from Illinois, and I want to thank several people that have contributed to this project. IDPH STD section staff that worked on creating the Access database, our IDPH lab staff that tested the specimen collection, transportation, and culture procedure and got it approved by our CLIA manager, especially Chris Voigt. Several CDC staff, including their laboratory that worked with us to refine our procedure, GISP staff, and our project officer evaluation TA provider, Brittany Johnson, who provided valuable feedback to us along the way. Here's our contact information, and I encourage you to reach out to us with any questions. If you have a specific lab procedure question, please reach out to Leslie specifically. My colleagues should be on to answer any questions today. Thank you.
Hello, my name is Karen Schlanger, and I'm the CDC project lead for SURGE, or Strengthening the U.S. Response to Resistant Gonorrhea. Today, I'll be presenting on test of cure return rates for patients identified through SURGE as having gonorrhea with reduced antibiotic susceptibility. Neisseria gonorrhea has developed resistance to every first-line antibiotic recommended since the 1930s, and presently, declining susceptibility to cephalosporins and azithromycin has raised great concern about the threat of untreatable gonorrhea. Unsuccessful gonorrhea treatment can be due to resistance, but also a number of other reasons, including inadequate treatment and pharmacokinetic factors such as a lack of sufficient antibiotic absorption in the affected tissue. And of course, possible reinfection always has to be ruled out. However, detection of treatment failures due to antibiotic resistance can be challenging, especially for asymptomatic infections. One way to detect treatment failures is through test of cure. Test of cure is the retesting of patients diagnosed with gonorrhea soon after they've received treatment to ensure cure. Test of cure can facilitate identification of gonorrhea treatment failures and thereby avert complications and limit onward transmission. This could be particularly important for containing the spread of resistant strains. Currently, CDC only recommends test of cure for patients with pharyngeal gonorrhea who have been treated with an alternate regimen. And data on how often patients return for a test of cure, what we're calling test of cure return rate, based on different criteria, are very limited. For this analysis, we sought to investigate test of cure return rates among patients notified as having gonorrhea with reduced susceptibility to azithromycin, ceftriaxone, or cefixime, noting that ceftriaxone and azithromycin are the current recommended treatment for gonorrhea, and cefixime and azithromycin an alternate treatment. For this analysis, we used 2018 data from the SURGE project. SURGE is a CDC-funded project in 8 jurisdictions and implemented in 16 STD clinics and 26 other health centers. SURGE sites collect specimens for gonorrhea culture, conduct antibiotic susceptibility testing on all positive cultures, and perform partner services, as well as recommend test of cure for all patients identified as having reduced susceptible gonorrhea, denoted here as RS and G. This slide shows the process SURGE uses for test of cure. Patients are tested by NAT and culture, treated as indicated, and any positive cultures are then tested for antibiotic susceptibility using the e-test. Patients identified as having reduced susceptible gonorrhea are interviewed and asked to return 8 to 10 days after treatment for a test of cure, which is typically performed using both NAT and culture. For our analysis, we considered visits as test of cure visits if test of cure was indicated as the reason for the visit. CDC also sent out feedback reports to the 8 jurisdictions, SURGE jurisdictions, on patients with gonorrhea tests documented within 30 days of treatment, but who didn't have test of cure indicated as the reason for their visit, and grantees could assess and recode as appropriate. For this analysis, we combined male patients reporting recent sex with only men with those reporting recent sex with both men and women in the category of MSMW. We also classified people as MSW or women. And we considered a patient to be symptomatic if they were reported gonorrhea symptoms at the site of infection. We calculated test of cure return rate overall and stratified it by month, jurisdiction, gender, and gender of sex partners, as well as symptomatology. We compared differences in test of cure rates among groups with chi-square, evaluated trends over time using the Cochrane-Armitage trend test, calculated time between initial and test of cure visits, and reviewed all cases with positive test of cure lab results to assess if likely due to resistance or other factors. So on to results. In 2018, SURGE sites performed susceptibility testing on gonorrhea isolates from over 4,400 patients, 9.6% of which were determined to have reduced susceptibility. Of those 425 isolates with reduced susceptibility, or 425 patients with reduced susceptibility, 91.4 had reduced susceptibility to azithromycin and 4% had reduced susceptibility to ceftriaxone and or cefixime. This chart illustrates the number of persons identified with reduced susceptible gonorrhea by jurisdiction, gender, and gender of sex partner. MSM/W are shown in dark green, MSW in yellow, and women in red. What's important to note here is that there is a wide variability across jurisdictions in terms of how many patients with reduced susceptible isolates were identified, noting that almost 40% came from New York City. New York City is the tall bar on the right side. You can also see that some jurisdictions have high proportions of female and MSW patients with reduced susceptible gonorrhea than others. On the left graph, you can see the racial and ethnic distribution of persons identified as having reduced susceptible gonorrhea by jurisdiction. And on the graph on the right, we see the percentage of persons identified as having reduced susceptible gonorrhea who were symptomatic by jurisdiction. These differences in symptomatology in part reflect differences in collection criteria used in the different jurisdictions. The heterogeneity found across sites in terms of number of persons, demographic and clinical characteristics suggest our findings may benefit from controlling for some of these factors in future versions of this analysis, which we are planning to do. This graph illustrates the overall test of cure response rate in 2018. You can see that the overall rate was 55%, but varied by month with the low of 42% reported in December and a high of 73% reported in April. Using a log binomial regression to estimate the test of cure return rate over time, we see the test of cure response rate appears to decrease as the year progresses. However, this trend or negative slope was not significant. When we look at test of cure response rate by jurisdiction, we see that 6 of 8 jurisdictions have fairly high rates, from 58 to 77%, while 2 sites, including New York City, have much lower rates. Because close to 40% of patients with reduced susceptible gonorrhea in our analysis come from New York City, we see that the overall test of cure rate across SURGE sites of 55%, indicated in light blue on the right-hand bar, is substantially lowered due to the influence of the test of cure rate in New York City. We also calculated the median number of days between initial clinic visits and test of cure clinic visits for the 425 patients identified with reduced susceptible gonorrhea, and found it to be 13 days, with an interquartile range of 10 to 19 days. The graph also illustrates time to test of cure by weeks. As illustrated in the figure on the left, we saw a higher test of cure response rate among females than males, but our analysis includes very few female patients, and this finding was not significant. On the other hand, we saw a very large difference between test of cure response rate for gay and bisexual men compared to heterosexual men, 58% and 34% respectively, and these results were found to be significant. And perhaps not surprisingly, we also found asymptomatic patients that were informed that they had reduced susceptible infections were significantly more likely than symptomatic patients to return for a test of cure visit, 64 versus 50%. Well, we also found that Black and African American patients with reduced susceptible gonorrhea were less likely to return for a test of cure than white, Hispanic, and Asian patients. Again, we will see if all these findings hold once we control for differences across jurisdictions. 12 of the 232 patients who returned for a test of cure tested positive for gonorrhea at this test of cure visit at the anatomic site formerly found to have reduced susceptible gonorrhea. This was 5.2% of those who returned. Upon investigation, we determined that none of these 12 patients had a treatment failure due to infection with a resistant organism. This finding wasn't surprising given that the susceptibility results from these patients suggested most infections had very low levels of antibiotic-reduced susceptibility. For 5 of these patients, it was suspected that the test of cure NAT was a false positive due to a NAT being performed before residual gonorrhea DNA cleared, which typically takes about a week. And for 5 other patients, we suspected likely reinfection based on reported interval sex and/or different AST profiles for the new gonorrhea isolate obtained. For 1 patient, the initial treatment was inadequate. In this case, they were initially treated with doxycycline for pharyngeal GC. And for 1 patient, the reason for the positive test of cure is unknown, as the patient had ceftriaxone susceptible gonorrhea, didn't report any interval sex, and test of cure was performed after sufficient time for RNA clearance. This analysis has a number of limitations, including potential differences in implementation across jurisdictions in terms of how test of cure as a reason for visit was applied and how test of cure patient messaging was implemented. Other limitations include the potential for missing data if a patient went to a non-search provider for their test of cure visit. We also know that time to test of cure data may actually overestimate time between treatment and test of cure, which is ideally what we would be interested in measuring, but was not available from our data set. In summary, SURGE sites successfully incorporated test of cure into their clinic flow for patients found to have reduced susceptible gonorrhea, and over half returned to a test of cure visit. I will note that this test of cure rate in SURGE is substantially higher than other test of cure analyses performed in the US, and similar to the test of cure rate reported in one large UK analysis. Test of cure return rates in SURGE varied by jurisdiction and patient population. Further investigation is needed to better understand these differences. For example, if and why MSW appear less likely to return for a test of cure visit than gay and bisexual men, and will require weighting and adjusting results by factors such as jurisdiction and symptom status. We did not identify any treatment failures due to resistant organisms, but found about 5% of test of cure results were positive. Beyond documenting test of cure rates among patients identified as having reduced susceptible gonorrhea, this analysis also provides an estimate of possible return rates and projected test of cure positivity if use of test of cure expands in other ways for active gonorrhea treatment failure surveillance. We can also benefit from future work that investigates test of cure burden on staff, clinic, and patients, such as assessing if other priority patients are turned away because of test of cure activities, ways to streamline test of cure specimen collection, and the value and cost effectiveness of conducting test of cure in different scenarios. Thank you for listening to my presentation, and I want to acknowledge all of my co-authors from the 8 SURGE sites and CDC, as well as all of the SURGE site staff that have implemented these important activities. My Q&A session is scheduled for Tuesday, September 21st from 4:30 to 5, and otherwise please reach out to me if you have questions or comments. Thank you so much for your time.
Hi, my name is John Pfister. I am a microbiologist and epidemiologist with healthcare education and training under a contract with the Wisconsin Division of Public Health. I'm going to be reporting on some data that highlight the importance of collecting extragenital culture specimens when conducting antibiotic-resistant gonorrhea surveillance. The study that was conducted in Milwaukee, here are my co-authors. It's truly an interdisciplinary effort, working with the folks at the State Health Department in Wisconsin, as well as the Milwaukee City Health Department, the Milwaukee City Public Health Laboratory, and the Keenan Health Center in Milwaukee. There's a picture I like to use of me, even though it's many, many years old. I can call it now my pre-COVID-19 picture, I guess, because here is my safer at home picture taken just a couple of weeks ago. So let's talk about antibiotic-resistant gonorrhea surveillance. It traditionally was performed through the EGISP program that began in 1986, where it was focused on males attending STD clinics presenting with gonococcal urethritis. And since then, just very recently, it's been expanded to include extragenital specimens from these males as well, and also to start testing some females. But recently, with the strengthening U.S. response to resistant gonorrhea program, or the SURGE program, we have more of an opportunity now, because we are routinely collecting specimens from extragenital sites in both men and women that we normally had never collected before. Now that we are collecting them routinely, it presents a greater opportunity to do AST testing, antimicrobial susceptibility testing on those specimens. So the Milwaukee City Public Health Department Keenan Sexual Health Clinic is the SURGE STD clinic SURGE site for the Milwaukee jurisdiction. We began collecting cultures and e-testing there in April of 2017. The data I'm going to present are up through October of 2019, but it's still ongoing data collection, so we'll have updated numbers to present at a future time. All patients who attend the clinic, the Keenan Health Center clinic, are interviewed regarding the gender of their recent sexual partners, as well as ascertaining all the sexual exposures to any and all anatomic sites. And then patients meeting defined risk criteria that I'll talk about in just a minute had GC culture specimens collected by InTray at all exposed anatomic sites. The patients were classified into gender and sexual partner categories as follows. Men who had sex with men were classified as MSM. Men who had sex with women only as MSW. Women who had sex with men as WSM. Women who had sex with women only as WSW. Men and women with both same and opposite sex partners, for the purposes of this analysis, were classified as MSM and WSM, as the numbers were very small as those who reported both sex partners. The culture and criteria that were used were, first of all, anybody who presented as a contact to GC, either self-report or upon referral from by the health department, were cultured for GC. All men who reported sex with men were cultured regardless of whether or not they were symptomatic or whether or not they were contacts. All symptomatic women who had mucopurulent cervical discharge were cultured, as were men with penile discharge. And then all patients returning for GC treatment following a positive GC NAT were also cultured. The antimicrobial susceptibility testing was performed on all GC isolates using e-test to determine the MIC that would indicate reduced susceptibility to any one of three antibiotics: azithromycin, cefixime, or ceftriaxone. So to summarize the results that we saw, we had during this time period 761 patients who had both a urogenital specimen and an extragenital specimen performed or cultured for GC. Extragenital meaning either a pharyngeal and or a rectal specimen. And of these 761 patients, we saw 335 of them that were positive at any anatomic site, either one site or multiple sites. And of these 335 patients who were positive, 49 patients had isolates available for AST testing only because we had done extragenital culturing. 49 patients who were positive for GC were not positive at a traditional urogenital site, but they were positive only at an extragenital site. Then when we performed AST testing, what we found is that in the 49 extragenital only positive patients, we found 8 of them with reduced susceptibility to azithromycin. So that 16.3% in the extragenital only group compares with the what we found in the genital culture group, where 41 of 286 positives were azithromycin reduced susceptibility. So similar percentages in both groups. We did find 2 suffixing reduced susceptibilities in the genital culture group, but no ceftriaxone resistance in that group as well. So let's look at the gender and sex partner gender groups by anatomic site. So we start with the males who have sex with men. These are men who are GC positive with both urethral and pharyngeal sites cultured. So they were cultured at both of these sites, urogenital and pharyngeal. There were 45 men who have sex with men who were positive in this group. 5 of those 45, or 11% of them, were positive only in the pharynx. They were negative in the urethra, but positive with the oral specimen. Among men who had sex with men, the rectal sites of 41 men who were positive, among 41 MSMs who had both urethral and rectal specimens collected, 12 of those 41, or 29%, were positive only in the rectum and not in the urethra. For men who had sex with women who were cultured at both the urethra and pharyngeal sites, there were 185 who were positive there. Most of them were positive either orally in the urethra or in both, but there were 12 of those 185, or 6%, who were positive only in the pharynx and not in the urethra. Then for women, women who had both an endocervical or vaginal swab and a pharyngeal swab taken for culture, there were a total of 77 positives in this group, and 19 of them, or 25%, were positive only in the pharynx and not in the genital site. Among women who had sex with men with rectal specimens taken, numbers were much smaller here. We did have 11 women who had sex with men who were positive for GC, and of those 11 women, 3 of them, or 27%, were positive only in the rectum and not in the genital site. And then again, very small numbers, but women who had sex with women, we had 9 women who were positive, women who had cultures taken both at a genital site and at a pharyngeal site. There were 9 that were positive, and one of those 9 was positive only in the oral specimen and not in the genital specimen. So, and what these data mean to us, I think, is that when we're conducting antibiotic-resistant gonorrhea surveillance by culturing and e-testing, it's important for us to make sure that we test as many extragenital sites as we can among people who are at high risk and are exposed at those sites, and that we should be collecting those GC cultures from both men and women, and both women who had both men and women who had both opposite and same-sex exposures. Now, even though this study is using ARGC data with cultures and e-testing, we think that this has implications for routine diagnostics as well, and should be fully explored as to what is the utility and the efficiency, really, of being able to detect GC infection by looking at extragenital sites as well as urogenital sites. So thank you. I would welcome any opportunity to answer any questions or entertain any comments during our live Q&A scheduled for Monday, September 21st at 4 o'clock Eastern Time. So I hope to talk with some of you then. Thank you very much.